Is my screen visible, Mohan? Yeah, perfect. Okay, sure. Thank you. So once again, let me thank the organizers and thank you to Endocrine Society of India, Dr. Kaushik Pandit sir and Dr. Hari sir for having me for this. Let me first say before I begin that I had exactly 24 hours to prepare for this. This talk was for Dr. Kaushik Biswas, but he could not join because of some health reasons. I have taken a lot of liberties and inspiration from some slides from his presentation, which I've incorporated into mine. Bone turnover marker, even when I was a student, used to give me nightmares to present it in front of elite endocrinologists. I had, basically nightmares the whole night. But having said that, I'll try to do my best. And my idea is to try to make it as simple as possible and as easy as possible for you to understand. Now, the first thing I did when I was asked to talk on this topic was to really, and I'll tell you a backstory to this. So we actually, we are very confused about bone turnover markers when we are practicing. This is about 7 or 8 years back when we actually started our practice. So a bunch of all young endos from Gujarat, we all got together and we said that what should we do about trying to understand bone turnover markers. So somebody told us that the best person to learn bone turnover markers is Dr. Thomas Paul sir. So what we did was, that time we wanted him to come to Ahmedabad, but because of some logistic reasons, he could not travel. So we actually arranged a webinar, something like this, for us to basically learn about bone turnover markers from Thomas Paul sir. And sir taught something which I still remember. It was outstanding, and I don't know if sir is still there. And sir, I don't know if sir still remembers. But so what I did, last night was basically to go back and listen to the talk. We had the recorded, just like Dr. Sri Nagesh sir has all the archives of the best cases that he has. We have archives of some of the best presentations that we have listened to, and we went back to that. I listened to that talk. So whatever I'm going to tell you, is what I learned from Dr. Thomas Paul. Basically hats off to him, because a lot of the work which you see is from CMC fellow Dr. Sahana, Dr. Nitin Kapoor, and Dr. Thomas Paul sir's work. So let me first start with this, right? A very fundamental point, which management guru Peter Drucker always says: what gets measured gets managed. Now, one of the biggest challenges of osteoporosis management is actually you are basically doing a DEXA scan every few years, right? But unfortunately, that the measurement of the same and how you interpret that often varies, and neither the patient and a lot of times not even the doctor is very confident about interpreting a serial DEXA. Also, we do not know, there are a lot of variations there. Now, if you compare that to another chronic disease, which is diabetes, what we see is diabetes gets managed much better because of the fact that you have better means of measuring the disease. You have HbA1cs, you have blood glucose values, now your CGM also, right? So because you measure it better, you tend to get more focus, you are more involved in it, your patient has more compliance with the care. Whereas if you compare that with osteoporosis, the challenge is because the measurement tools are not that, not that perfect, the measurement often gets lagged behind, and because of that the management also kind of lags behind. The patient is not that involved in the care of an osteoporosis as they are as they are involved in diabetes care. So I think that is the major thing, and that is where bone turnover markers are very useful, because they solve this problem. It's again a blood test just like the other blood tests which your patients do, and with that the patient is able to actually understand the progress, the clinician is able to understand the progress, and in some cases also modify the treatment based on the thing, right? So this is the outline for my talk today. I'm going to introduce bone turnover markers to you. We are going to see the clinical use cases for bone turnover markers, and then I'll give you some practical tips, what I have learned in my practice and what I've learned from Dr. Thomas Paul sir. So that is what we are going to do in today's talk. So let's start with understanding bone turnover markers. Now, to this elite audience, the bone remodeling cycle is very well known. I don't have to tell you this. In fact, you will probably tell me, right? So the bone turnover markers is, the bone remodeling cycle is very well known. What we know essentially what we need to understand, and for the audience who are not endocrinologists, what I'll say is, what we basically need to understand is that the bone formation and bone breakdown are linked together. They are married together. They move together. So whenever you have bone formation, you have bone breakdown. When you have bone breakdown, and when you have bone formation, so it's a well made system. Sometimes this system breaks down, so you have more bone formation and less breakdown, which is rare, but you have more breakdown and less formation, which is common, right? So that is what we typically see in a lot of situations, and that is basically leads to a lot of pathological issues. So the simple idea is that you have certain tests or certain ways in which you measure bone formation. So you either measure the bone formation or you measure the bone breakdown. In most cases, both the things happen in parallel. In certain situations, there might be some sort of a discongruence to it. So sometimes there might be less formation and more breakdown, and vice versa. So with bone turnover markers, you are measuring either the bone formation, bone breakdown, or both, and then you are interpreting the whole thing in context of the clinical situation of the patient. Okay, so in that context, if you see a DEXA, so I would just compare this in the same way as you do as an HbA1c and a CGM. So an HbA1c gives you a static picture. Same way, a DEXA scan gives you a static picture of the patient's bone situation. You did a DEXA, you repeated the same after 1 year, maybe after a couple of years. So you are getting a static picture of what is happening at this point of time. Whereas a bone turnover marker, because you measure it more frequently, you are getting a dynamic picture of the things that are happening, how the patient is responding to your treatment, whether the patient is compliant with the treatment, and so on and so forth. So that's why bone turnover markers play a key critical role in the management of osteoporosis, because they give you a more current and hands down and more dynamic picture of the process which is ongoing. Now, I told you there are bone formation markers and there are bone resorption markers. So bone formation markers, you have P1NP, which is the most popular, and the bone resorption marker, you have CTX, you have NTX, and you have TRAP5B. So you have this three classical bone resorption marker. Bone specific alkaline phosphatase is another popular bone formation marker, and osteocalcin is another popular bone formation marker. So as you can see from this simple slide, that you have certain markers which are bone formation and certain markers which are bone resorption. Now, always remember this. So again, if you put it in context of what I showed you in the earlier slide, bone turnover markers are not to be interpreted in isolation. They are not substitute to a bone density. They are complementary to bone density. Just like, for example, a CGM is not a substitute to an HbA1c. It's complementary to HbA1c. So you will do HbA1c to get the big picture and the risk of complications, and you will do CGM to look at the nitty-gritties of the diabetes management. So where would you like to add another anti-diabetic agent? Which are the problem areas? Which are the situations where the patient is hypoglycemia and hyperglycemia? In the same way, with a bone turnover marker, what you're doing is you are looking at the current ongoing situation, whereas you are with the DEXA or a BMD DEXA, you are getting the whole picture, you are getting the big picture in the patient situation. So this is how you basically would look at bone turnover marker vis-a-vis a DEXA. So now this is one thing which literally changed my clinical practice when I listened to Dr. Thomas Paulser. And what Dr. Thomas Paulser told us, that you don't have to worry about so many bone turnover markers, right? There are so many of them. There are, there are again different values to that. There are different pre-analytical issues with bone turnover markers. What you need to do is you just need to focus on two. One bone formation marker, one bone resorption marker. The one which are standard of care and which most of the international consensus guidelines suggest is you have to measure just two and measure and monitor just two of them. For bone formation, you use serum P1NP, and for bone resorption, you measure the serum CTX, right, which is the also known as beta cross lab. So basically, and my rest of my talk is going to be focused on these two markers. So we'll be looking at, from the bone formation perspective, a P1NP and a CTX from the serum CTX from the bone resorption marker. Now, there are certain urinary bone resorption markers also. Let's not confuse the matters. We will just focus on, and again, my idea is to simplify things. We'll just focus on these two bone markers, the serum P1NP and CTX. And if we will do all the rest of our understanding and interpretation based on these two markers. Now, some alternative, we have bone specific alkaline phosphatase, which is a good marker, especially patients with CKD. And if you want to see TRAP5B, again a good marker for CKD patients. So these are special use cases, but in most cases, you will be using one of these two. Now, just like any other tests, well, bone formation markers or bone turnover markers are very fickle. There are a lot of issues with, just like any other endocrine test. You will have to do it in the morning as a morning collection in a fasting sample after an overnight fast. Generally, there are circadian issues also, so you have to measure it at a particular time. Again, there could be serial measurements which would lead to changes, and then again there is some bit of patient preparation also required. The patient has to avoid vigorous exercise, and again especially for 24 hours prior to collection. So there could be again pre-analytical issues with interpretation of the results, and again you have to interpret the results based on the clinical context of the patient and not just in isolation. Especially now, serum CTX is definitely affected by multiple factors. Like I said, there is a circadian rhythm, there is a circadian variation. Again, food intake will lead to reduction of the CTX values. Same with glucose status, so especially in uncontrolled diabetes also, there could be slightly lower serum CTX values. And renal failure also will lead to misinterpretation of the CTX. So always remember that whenever, just like any other endocrine test, whenever you are measuring these tests, you have to measure it in the context of the clinical situation which the patient is having. Also, additionally, there are population specific reference ranges which are required. Again, all these bone turnover markers will be affected by genetic factors. They will be affected by environmental factors, including vitamin D status, a lot of the dietary and lifestyle patterns also. And again, there are ethnicity based issues also. So again, there are ethnicity based BTM ranges also, which is available. For more on this, I'll introduce you to a very, an excellent, and this is what I read last night, an excellent review article by Dr. Sahana. Along with Dr. Thomas Paul and Dr. Nitin Kapoor, they wrote this paper. It is published in Indian Journal of Endocrinology and Metabolism in 2016. So, Clinical Endocrinology in 2016. So that is the paper I would suggest you should consider reading on this particular topic. Having said that, there is an article published in 2023 by Dr. Vasikaran, where this is an Asian consensus statement on the normative values for these two essential bone turnover markers. And these are the values which they have suggested, and I'll suggest that is what we'll use as a normal reference range. So P1NP values of 15 to 70 microgram per liter, and beta cross slabs, that is the CTX, you will have 100 to 700 nanogram per liter. Just be careful about the units because in certain areas the units may differ. Okay, so now let's come to the clinical use case. So this was the introduction to the bone turnover markers, the basic introduction. Now we'll see how you'll use bone turnover markers in your own clinical practice and how you can interpret the results based on the clinical practice. Now the first use case, which is very intuitive, is to use bone turnover marker as a third umpire. So in situations where you are not sure whether to treat a patient for osteoporosis or not treat, bone turnover markers can be that extra element, can be that extra third umpire, which will help you unravel and decide whether you want to treat or not. Now let me give you a clinical case scenario. And again, let me just say that all the clinical vignettes are actually given to me by Dr. Kaushik Biswas. So I've taken this clinical vignette straight, copied and pasted from his slides. So if you have any specific queries regarding the cases, please contact Dr. Kaushik. I'm going to just basically represent or re-represent the cases which he has said. So he has a very beautiful case which illustrates this point beautifully. So we had this 62-year-old female patient who came for evaluation. Now she basically had an osteopenia, and she had on her BMD, she had a T-score of minus 2.1. The indices basically showed reduced bone mineral density. They also did a FRAX, and they calculated the FRAX, and again the FRAX risk was 5.5% for major osteoporotic fracture for a 10-year risk probability. Again, does not come in the classical range where you should consider treating, right? So in this case, you are now in the dilemma or whether to treat or not to treat, right? So you are in this situation. Now this is where in such situations, the bone turnover markers can be very useful. So what Dr. Kaushik did, that he measured the CTX value, and he measured the CTX value, it came out to be 1.45 with a normal range of less than 1.01. Again, remember, like I said, it will be 145 nanogram per liter. So just be careful about the units. Now the values are actually higher. So what this tells us is that the patient is having more bone breakdown. And in that situation, your tendency towards treatment increases. So you are probably then considering to treat. Right, so your error in the side would be to treating rather than not treating. So in that case, in this situation, Dr. Kaushik Biswas decided that this patient should be treated. Just that you are not very sure, but this turned out to be a sort of a little bit of a third umpire for you to consider, or an additional parameter to consider for treatment. Now, you will then tell me that, Om, is this clinically validated? Actually, there are a large number of studies which have actually looked at addition of bone turnover markers to the existing evaluation parameters for treatment of osteoporosis. And for example, this is a study by Dr. Garnero, which looked at combining the hip BMD along with CTX, and what they found was that you had a better fracture predictability with combining these two parameters instead of trying to interpret these two parameters in isolation, which is again very intuitive and again easy to understand. But having said that, this one study which was very impressive was by Jonel back in 2002 by in Osteoporosis International. Remember, just like you have some of the elite journals like Diabetes Care for Diabetes, you have Osteoporosis International, which is the elite journal for osteoporosis. And in this, basically, they simulated a hip fracture risk probability based on various combinations of risk factor parameters, and what they found was this one, right? So urinary CTX with a prior history of a fracture is the strongest marker of a future risk factor for hip fracture. Again, of course, a prior fracture definitely will tilt the equation towards it. But secondly, and the parameter which I think would be more useful in a primary prevention cohort would be a BMD with a urinary CTX, or in our case, of course, a serum CTX would be a good marker, second best marker for predicting the risk of a future hip fracture. And then you look at BMD with a prior risk fracture, prior hip fracture, and then or a prior fracture, and a urinary CTX with a prior fracture. So again, they have combined this, and you can see where BMD really comes. It comes way bottom into the equation, right? So all these things, so all these situations where you are combining two parameters, risk parameters, you are getting a better answer. Well, this type of model in 2002 is ripe for being evaluated with a machine learning AI based model, right? Perfect. If you just get this data, you could actually reevaluate this data and perfectly with AI, and you will get much better insights in terms of the predictability. But having said that, the idea, even with this simple elegant paper, is that what I'm trying to put to your mind is that you adding a bone turnover marker in the risk evaluation does add more value to the predictive power, and hence it should be considered in these situations like where you are not very sure whether to treat or not. Now, more important than starting treatment or not, it's more important to really use bone turnover markers for monitoring response to therapy and adherence to therapy. So I think this is a more useful use case for bone turnover markers. I think this is again an area where you have a wide gap. You have an area of need, and this area of need is actually fulfilled by bone turnover marker. Again, so just to give you a very simple simulation to understand, let's say you are following up a patient by doing a serial BMD DEXA. Then what you'll be doing is typically you'll get a more reasonable value at 2 years, right? So at point 0, you started the patient on treatment, and then at end of 2 years, either the patient gets better or the patient gets worse. You will only know at the end of 2 years. So you already lost a bunch of time in that regards. However, with a bone turnover marker, within 3 months itself, you will get some idea of where the patient is heading, whether the patient is heading in the right direction, or whether you need to optimize the treatment, or whether you need to reinforce adherence to treatment, right? So that's why you get much early a prediction of how the patient or where the patient is going, instead of waiting for 2 years for really getting the whole picture, right? So I think that's why bone turnover markers, and again very elegantly shown by this simple slide, tells you that bone turnover markers gives you a early idea of where the patient is headed towards, and then hence you can then course correct or see whether you're going in the right direction. So typically, again, a rule of thumb is something like this, that whenever you initially start, you do a baseline CTX and P1NP, and typically the bone breakdown markers, that is the bone resorption markers, typically normalize in about 3 to 6 months, but a bone formation marker will generally take a slightly longer time, that is 6 to 9 months to normalize. So this is the typical path you will understand. And then what kind of change in the value would you consider to be good? So basically you should consider, in the least significant change, that you should consider 30% change in the CTX value, or 20% change in the P1NP value, to get the actual picture of where the patient is headed towards. Now, this is a very important and fundamental point. Remember, the type of therapy will also determine your response to the bone turnover markers. So I think this is again it's intuitive to understand, but just to reinforce this point very strongly, when the patient is on an anti-resorptive agent like a denosumab or a bisphosphonate, then it will suppress the bone turnover marker. So you will have a reduction of P1NP and CTX value. Whereas if the patient is on a teriparatide, there will be an elevation of P1NP value, which is what you're monitoring. And this is elegantly shown by this picture, this cartoon here, where basically the patient initially is on a teriparatide. You can see there is an increase of P1NP, increase of bone formation, and also the a little bit of increase of NTX. Also remember, a teriparatide will increase the bone turnover, whereas when the patient is on an alendronate, what you are seeing is this. You are basically seeing that there is a suppression of these bone turnover markers. So that is what you should keep in mind, that the type of therapy which the patient is on is very, very important to use that. Again, if the patient is on an anti-resorptive therapy, your idea again, what therapeutic goal would be to suppress CTX to value of less than 0.3 or P1NP to a value less than 35. So that is what you will be looking for in terms of the therapy. And again, if the patient is on a bone anabolic therapy, within 1 to 3 months, you will expect a good response to therapy would be an increase of P1NP by greater than 10 microgram per liter. So that is what you're looking at. So remember this slide again. So P1NP increase of more than 10 is considered a good response to therapy. Whereas if it doesn't increase, then you are probably looking at maybe adherence issues, or there could be, again, in terms of, there could be other factors also, maybe the injection technique, storage errors, poor adherence, and so on and so forth, right? So that is what you'll see. Now, $1 million question is, how does it really work with Romosozumab? Remember, Romosozumab has a dual sort of action. It is anti-resorptive as well as a bone anabolic. And what you will see is, what you see on the top, on the dashes, with the dashes, this is P1NP, and what you see in the bottom is the CTX. So there is a dual response here as well. So initially, with a patient on Romosozumab, there is a transient increase of P1NP, and then P1NP reduces and it gets suppressed. And CTX, there is a transient drop in the CTX value. Then again it comes back and then it keeps dropping, right? So it keeps being suppressed. So when you finish the treatment after 1 year, typically both the values will be suppressed. But P1NP, there will be a transient increase, which you have to keep in mind when you are interpreting the results in the light of the clinical parameters. So again, with Romosozumab, you should be aware of these clinical parameters. Another useful thing, and this again I learned completely from and I had no idea before I read his paper, and before I interacted with Dr. Thomas Paul. This is something which he taught me, which I still remember and still, in fact, use in clinical practice also. A bone turnover marker could be very useful for actually guiding what kind of therapy you should consider. So baseline bone turnover marker, and if you find that the P1NP and CTX both are increased, so you have both increase of bone formation as well as the bone breakdown marker, that basically shows that you have high turnover. And then in such cases, you should probably consider using an anti-resorptive, right? So you have increased turnover and then you want to suppress that. So that is what you should consider doing. On the other hand, if you have both the things decreased, so you have P1NP which is reduced and the anti-resorptive is either, again, the resorption markers are either reduced or normal, in that case you have a sort of a hypodynamic state of the bone, some sort of adynamic state, and in that case a bone anabolic agent would be a better choice. And then when you have this flipped thing where you have the bone formation marker which is reduced and bone resorption marker which is increased, then in such situations you can consider either of the therapy, but you first consider giving a bone anabolic and then anti-resorptive, right? So this type of dual therapy would be useful. So you can actually use this therapy, the bone turnover marker to really guide the form of therapy which you want to give. And I actually use this, this is especially useful in situations where you are not very sure of which therapy to give for osteoporosis in this case. Now, another very useful use case, again explorative, but could be potentially very useful, is to help you in diagnosis of a secondary cause of osteoporosis. Now, again, what people have seen is that the molecular signature, so whether it's the biochemical signature, that is, what kind of, there is a differential in terms of bone formation and bone resorption, you could actually get some sort of a differential diagnosis in terms of the metabolic bone disease. Additionally, if the bone turnover markers are very high, especially the bone resorption markers are high, you could probably then look at potential secondary cause of osteoporosis rather than just depend on primary osteoporosis. So that is again a very useful thing. In fact, this is a expert recommendation from Dr. Kaushik Biswas. Like I said, originally slides, some of the original presentation was made by him. What he has very categorically stated is that baseline raised resorptive marker is a clue for you to look for secondary cause of osteoporosis. Again, this is an expert opinion. This is not a clinical recommendation. Again, to give you an example to illustrate this is a case which he has shown. So this 54-year-old female actually came with osteoporosis, and on face value things look pretty much okay. But what Dr. Kaushik thought was, in terms of digging deeper, is that he found that the serum beta cross level, the CTX values were very high. So you can see, almost 380, right? So pretty high. 3 times the upper limit, in which case what he's then thinking is that probably this is not a routine case of osteoporosis. Remember, this lady is also just 54 years old, and then they dug deeper, they looked at the secondary cause, and they found that the patient actually had celiac disease. So I think again, testimony to the fact that when you have something not fitting into the equation, you could probably look at this in a light. And again, from this slide, you can really see that sometimes the the biochemical signature of the bone turnover markers can give you a hint towards a diagnosis. And let me point out to you one typical situation. You see this with multiple myeloma. So you have increase of bone resorption marker and reduction of bone formation marker. So again, you should, if you have such a situation with possibly a hypercalcemia, well, why not look at multiple myeloma as a cause? And very interestingly, diabetic bone disease has a reduction of both, right? So again, you have reduced bone formation as well as bone resorption markers. They are on the lower end. Well, that makes me think, why not consider teriparatide as a standard of therapy in diabetic patients with osteoporosis. Again, with glucocorticoid therapy, there will be a flipped ratio, so there will be increased bone formation, bone resorption, and reduced bone formation marker. So again, what I'm trying to tell you is that based on the biochemical signature, you may be able to make a certain clinical diagnosis. It will hint towards a certain It's not that it's going to make you the diagnosis. It will hint towards a particular diagnosis. Again, this could be useful in clinical practice. Finally, one important use case which all of us, of course, not many of us use it, but it could be something which could be useful once we start giving drug holidays to patients on bisphosphonates. What you could do is that the bone turnover markers could actually be very useful in monitoring the patient during the drug holiday. So let's say, you started the patient on zoledronate, and after 3 years, you give the patient a drug holiday. Then what you do is you serially measure the bone turnover markers. And if the P1NP starts increasing, right, or if the CTX value starts increasing, at that point of time, you should probably consider discontinuing the drug holiday. And if the patient continues to have suppressed values, then you can probably continue the treatment, continue the patient on drug holiday, right? So this could be a good guide towards when to restart treatment or whether to restart treatment at all in such situations. Again, with a margin of safety. Remember, what you're doing is you are then also preventing some sort of a adynamic bone disease and fragility fracture and atypical femur fractures by doing in this manner, right? So by actually looking at where we are going. Remember, the adynamic bone disease is a situation where you have atypical femur fractures, and by monitoring in this manner, you are actually preventing this from happening. So again, this is again a little bit of an insight which you could look at, right? So finally, the last few slides, practical tips and tricks and how I typically tend to use bone turnover markers in my own clinical practice. So first thing I'll say is, before you start osteoporosis treatment, and if your patient can afford it, and if your labs have this available, you should definitely consider doing bone turnover markers. Just do 2 tests, P1NP and your CTX. First of all, it will help you decide whether to treat or not to treat, especially in cases where you require some sort of a referee. Again, it will help you decide what kind of agent you should consider for treatment. So what would be a choice of agent? It will help you give you a baseline value which you could use for monitoring therapy. So again, if you want to look at the compliance of the patient, you could look at that. And then you could potentially rule out secondary causes, especially if the values are abnormal or very high, the bone resorption markers. You could probably then dig deeper to look at a secondary cause. And again, once you have started treatment, how does bone turnover marker really help you? It helps you monitor response to therapy. It helps you monitor adherence to treatment. And again, especially if the patient is on a drug holiday, it could potentially, you could decide when to end the drug holiday for patients on bisphosphonate. So finally, and this is what I'll end up by saying, I showed you the use cases. I showed you different ways in which you could use bone turnover marker. But I often feel, and this is my little take, is that bone turnover markers are actually very delightful. A lot of research use cases. It's a key. We know that there is something there, but it's a key trying to find its perfect lock, right? So that is what I'll see. The exact use case, we are still not narrowed down that this is exactly where you'll use bone turnover marker. It's left to a creative freedom, and it left to clinicians and researchers, overall a situation of where they want to use it. Definitely useful in research, but in clinical practice, we are still trying to find that perfect lock. So that's what I'll end with. Thank you.